All right, we'll go ahead and get started here this morning. This is Peter Brissett with the Colorado Assisted Living Association. Thank you for joining us on this webinar this morning. The title of the webinar is New Healthcare Paradigm and Assisted Living. And joining us today is Steve Moran, and I appreciate him taking the time out for us. Steve runs the blog Senior Housing Forum. It's the fastest growing senior housing industry blog. It's seniorhousingforum.net. And he's been involved in the senior housing industry since 1980 and has developed and operated a number of assisted living and CCRC communities. His day job is a business development officer for VHIL Health Solutions. That's vhil.com. And VHIL provides wireless and wired emergency call systems, including their award-winning memory care call system. And he's joining us today live from Sacramento, California. Is that right, Steve?
That's correct.
All right, so what I'm going to do here is go ahead and transfer this over to Steve. Again, if you have questions throughout, just ask them in the box so either I or Steve will see that, and we'll try to get that into the presentation. So Steve, you should be able to take that and share your screen.
Okay, that, and so I'm assuming you can see my screen now?
Yep. Can you
Okay, terrific.
I just need you to close the question box there. It's still floating on top.
Okie dokie.
Or is that mine? That's not yours. That's mine. You're good. It's all you, man.
Good?
Yeah, you're good.
Yeah. Yeah, I was thinking that mine would float on top without showing up on anybody else's screen.
No,
so,
you're fine. It was me.
Perfect. Okay.
Great.
Excited to be with you. Just do one little kind of correction here. It's actually Vigil Health Solutions. And Senior Housing Forum has been a blog that really is geared towards the senior housing industry. I'd say I probably focus mostly on assisted living because that's where most of the growth and the activity is happening right now. But we talk sometimes a little bit about skilled nursing, sometimes a little bit about independent living. And they're all pretty well interrelated, and so I publish new content every week on the blog. And yesterday afternoon I published an interview with Tiffany Tomaso, who was the Chief Operating Officer for Sunrise Assisted Living, who just got bought out by a big REIT that was announced yesterday or the day before. And she started a new company called Kensington Senior Living, where they're doing a very medical model assisted living program that really is designed to, in many cases, be an alternative to skilled nursing. And so it might be something you want to take a look at. And it's the reason I particularly mention that is because it's related to the topic we're going to talk about today. I'm going to just kind of do a little bit of a review here. What I want to talk about today are really two challenges. The first is, how do you get more than your fair share of available residents? I've written a couple of blog pieces where I've made sort of, I've addressed this issue, and I've been accused of being callous and interested in the bottom line and not caring enough for residents. And I guess it's an okay accusation to make, but the truth of the matter is that when assisted living communities are financially healthy, they're actually able to do a better job of caring for their residents, and sort of the old mantra that the not-for-profits use is no margin, no mission, and I think that really applies whether you're talking about for-profit or not-for-profit communities. And then the other thing I want to talk a little bit about is holding on to residents as their medical needs increase. And I think that my experience is that even though we've got this huge age wave coming, that what happens is that most buildings I talk to are not full, don't have waiting lists. They'd like to have a better resident population, and so ultimately this is about helping you to do that and helping to do a better job of taking care of the seniors in the state of Colorado. So I want to just do a quick sort of little review of assisted living today. We know that 10 or 11% of the population, senior population, that would potentially be eligible to live in assisted living who might benefit from it are actually living in an assisted living community, about 900,000 people across the country. We tend to oftentimes think in terms of our primary competition as being the guy down the street. If you're a smaller community, you think of it as the big corporate guys, and if you're the corporate guys, you think of it of everybody else. But the truth of the matter is that in reality, the biggest competition and perhaps the biggest challenge the industry faces is how do I tell the story in such a way as to demonstrate that living in a senior housing community, an assisted living community, once you start having needs for assistance with daily living, is really a better alternative than living at home with, say, home health or living with family members who are in and out and you become a real burden. Because the reality is, of course, that most people would prefer to live and age in their own home, in their own apartment. And so, as the community looks at assisted living, they see it as a loss of independence. They see it a loss of precious possessions. I just moved into a new house 2 weeks ago, and it's a bigger house than I've ever lived in. Hopefully, it's the house I'll live into until I need to go into assisted living. And having the ability to get stuff out of the box that we've collected a little through the years and be able to look at it. And I know that at some point in time when I get older and I need something like assisted living, that a lot of that stuff is going to have to disappear, and that's a sort of a hard thing for all of us to sort of have to wrestle with. And a lot of people sort of see it as the final downhill slide. I'm sort of the Hotel California. You go in, but you're never able to get out again. The other problem that I see in assisted living that I really struggle with, and Peter, I'm sure you see some of this as you do marketing work with assisted living communities, is there's lots of look-alike. The buildings look alike, the programs look alike, the web pages look alike, and so people primarily differentiate because of where buildings are located, and programming almost is secondary to that. And we see a lot of stuff in the press about the coming shortage. Several months ago, I saw an article that said we better be careful because there's this huge impending shortage of skilled nursing beds. And on one hand, it's fine to say that, but again, I still find that average occupancy rates are below 90% for assisted living. Skilled nursing is about the same. There's lots of new construction. I know that right now, wearing my hat for Vigil, on the emergency call side of things, I'm talking to 6 or 8, maybe as many as 10 people who are developing projects in Colorado. And so I'm not so convinced that we're going to be in a situation where anytime soon we're going to see this big wave that's going to make everybody full and fat and happy and those kinds of things. And the other thing is there's more competition, there are more choices. You're seeing home health that's being more and more aggressive in their marketing, assisted living without walls. People are moving in with relatives, particularly because of the economic situation. So as you look at the marketing aspect of senior housing, marketing mostly presumes, or maybe pretends is a better word, that the decision is primarily a lifestyle choice. And the reality is that people move, for the most part, into assisted living because there's been some triggering event that has forced this very difficult choice to move out of their home, out of their apartment, out of their family, because they need more services and more care than they can get where they're living. Is it ever a lifestyle choice? Maybe, but rarely. So I want to kind of just give you, I did a little bit of a search here in Citrus Heights, where I live, which is a suburb of Sacramento, of some websites, and I'm not picking on anybody in particular in case I'm hitting somebody who's actually got some ownership, because there's some big corporate entities in here. But I just want you to sort of look at some of the language that we see on the website, and you see that it's lifestyle based. So you've got, your lifestyle is important at Merrill Gardens. Choices are the key to enjoy a life you deserve. Carmichael Oaks Senior Living Campuses features 3 lifestyles. Catch that terrible typo on their front page. I actually did email them, and I went back. I didn't get a response to it, but I did go back and look at their webpage last evening, and they have fixed the typo. Carlton Senior Living, taking assisted living to its highest level. encourage active, independent senior lifestyle. And so I think that we don't always represent sort of what it really looks like for the average senior. And I think that we're going to continue to see seniors who are having higher, more complex needs. So when you sort of look at how people make the decision, the first thing is that it's one of those major life event decisions that people make. We talk a lot about how getting married, of course, is one of those high-stress life decisions. Having a spouse or a family member, close family member die is one of those high-stress, difficult decisions. Buying a new house, having your first child, those kinds of things. We don't usually talk about making that decision to move. And so I just think that as we deal with seniors, as we talk to seniors, as they get ready to make this transition, one of the things that perhaps we as housing people could do a better job of is really sort of talking and working with people as they go through that process. I think the one organization that probably understands how to do that better than any other organization in the sort of the senior housing, senior care landscape is hospice. They understand how they need to work with both the family and the person who is dying to help them work through their emotions and feelings and deal with the decisions that need to be made. And so I think there's a huge opportunity. I think right now what you see, the studies show consistently that the number one reason people choose a given community is location. Not really a part of this seminar today, but I sort of dream about the question of, could it be different? Could you create a senior housing community, an assisted living building community that was so amazing, so fantastic that people would be willing to drive 30 minutes and pass 20 or 30 other buildings in order to go to your community because it creates a lifestyle where there's still meaning and there's still passion. And so, but today that's not the way it is, and so usually, again, as I've talked about already, it's almost never a lifestyle choice. There's usually a triggering event. Family member discovers that dad's at home and not taking his medication, which gets him sent off to the hospital, or they walk in and mom hasn't taken a bath for a week and the place smells, and sometimes it's just worrying about safety. Somebody's had a fall where maybe nothing even happened, but they're worried about it happening again. And of course, nutrition is a big issue, as you know, as you're providing care. So if you look at what assisted living has traditionally looked like, sort of the yesterday look, there are lots of things that you can do to get more than your fair share. I think that I wrote an article last week where I talked about networking, and I think that networking is probably the single most important thing you can do. You'll find that if you go into a geographic area that is generally occupancy challenged, that you'll find one or two buildings that stay consistently full, and you'll find behind that you've got somebody in that building, either the marketing person and or the executive director, who has just this tremendous referral network. So the good news is that healthcare is changing dramatically, and it will either leave assisted living communities behind or it will create some huge opportunities, and so that's really where we're going to spend sort of the rest of the time. So if you look at the yesterday for assisted living, it was really an invisible piece of the pie to most of the rest of the healthcare system. Government doesn't pay for assisted living. Insurance doesn't pay for assisted living. It was perceived as being mostly a lifestyle choice. There was really just no compelling story that assisted living had to offer to the healthcare industry. Today, you start looking at our healthcare ecosystem, and healthcare for seniors is hugely, hugely expensive. I mean, Obamacare, when you look at it, is really all about the fact that it's so expensive that a lot of younger people can't afford insurance, younger families can't afford insurance. For seniors, it's a little bit hidden for us because the cost is mostly carried by the government through Medicare, Medicare Advantage programs. For people who don't have other assets, they've also got Medicaid programs that picks up the balance. as you look at the trend line for healthcare, costs are going up much, much faster than the cost of living. I saw something just in the last couple days where somebody was raising premiums on average 13, 14% against the cost of living that's hardly going up at all. And so when you look at it, Obamacare, which we now know is going to become the law of the land, is the law of land, is ultimately about insuring the uninsured and better managing those costs. So when you look at the landscape for seniors and how their care gets paid for, there are really two payment scenarios when it comes right down to it. You've got traditional Medicare, which is a fee-for-service program, and then you've got Medicare Advantage, and there are lots of permutations. You'll hear about things like HMOs, PPOs, fee-for-service, PACE programs, accountable care organizations, and I could talk a lot about all of those, but I think that the place where it really comes into play is that Medicare Advantage represents a very unique opportunity for the assisted living marketplace, and I'll dig into that a little deeper here as we go on. Are there any questions? I know I don't see anything typing here, but I want to just pause if anybody has questions. So traditional Medicare is eligible for almost everybody who's age 64 and older in the U.S. is eligible. Almost every medical provider accepts direct Medicare payments. It has bigger copays and deductibles than the Medicare Advantage programs generally. And the other thing is that in spite of industry press releases, the money coming out of Medicare is still pretty good. The other problem is that the government's going to go broke under that plan, and the money is not available to, has not been available to assisted living. Once you get to Medicare Advantage, it becomes a very different game. So at its most fundamental level, it's a capitated plan, which means that the government enters into a contract with an insurance company or a health provider organization where they get a capitated rate, a certain dollar amount per month per resident that they're taking care of. And at that point in time, they're responsible for ensuring that they get at least the same benefits as a traditional Medicare recipient. The Medicare Advantage programs tend to allow seniors to better manage their costs. Today, interestingly enough, initially when it was started out, it cost the government about 15 or 20% less than fee-for-service Medicare, but the way the plan has evolved, it's actually costing the government more than traditional Medicare, and so we're likely to see some big changes. There are also a number of special plans that deal with people who are essentially indigent, so the PACE program, some of the ACOs are doing that. But the big news is, and the reason this is really important to you as an assisted living provider, is that once a senior has signed up for a program that operates under the Medicare Advantage system, those dollars are potentially available to you as an assisted living provider. And today that's about 25% of the seniors who are enrolled in an Advantage type program. The other part of the equation that becomes really important to those of us who are involved in the assisted living marketplace is that hospitals have a brand new problem. I'm sure you've been reading about it. Originally, way back when hospitals received basically a fee for service, they would do an operation or a procedure, they'd create a bill, send it off to Medicare. Medicare would pay a cost-plus arrangement, and so hospitals got very, very creative at increasing costs because it meant increasing profits. And at some point, the government stopped and looked at that and said, wait a minute, this is costing a fortune. We have got to change that. And so they came in and they created all these diagnostic groups where they said, we've done some studies and we've discovered that a heart valve operation costs $50,000, and so we're going to pay you $55,000 for that, and if you can provide that for $45,000, you're going to make more money, and if it costs you $60,000, you're going to lose money. And so it was still very profitable for the hospitals, but one of the things we saw out of that came out of that was hospitals started to discharge patients much earlier, because once that bed was empty, it was available for somebody else, and they were making more money at it. And so what they were doing is they were sending home patients or sending patients to skilled nursing buildings where their medical condition was less stable, and as a result, over time, what we begin seeing is that those patients were, within the 30-day period of time, being readmitted back into the hospitals. It worked actually pretty good from an economic standpoint for everybody, because they'd readmit them under a new DRG or a fresh start DRG. The physicians would get to do more care. If they had been discharged to skilled nursing, as probably most of you are aware, skilled nursing can get, under certain needs for the resident, they can get up to 100 days of the care paid for by Medicare. They went back in the hospital for another 3 days, started that cycle all over, and so economically there was very little incentive to really make sure the patient was doing well. And so the problem was that while it was great financially for the physicians, for the hospitals, for the skilled nursing facilities, it wasn't very good for the residents, because it meant that their health care wasn't the most important thing, and it wasn't very good for the payer system, which was really Medicare, because they were putting out more money than they needed to, because the health care providers were not doing their job. So today it's a brand new game. It's just actually kicked in, but the hospitals are being significantly penalized for readmits that take place within 30 days after the discharge. I think this year it's 1 or 2%, and it goes up to 3 or 4%, and that represents really, really huge dollars for the hospital. And so all of a sudden, where the hospital didn't really care all that much about what happened in sort of a harsh sense to the residents, where the big goal was just to push them out and down the system, all of a sudden they've got to stop and say, should I keep, the first question is, should I keep this patient an extra day in the hospital in order to make sure that they don't get readmitted? Or perhaps more importantly, what they're doing is they're saying, we've got to look at where we're sending those patients after we discharge them from the hospital, because if I send them to a skilled nursing facility that does a great job of making sure they don't come back, I've made money. If I send them home and I've got a great home health agency so that they don't come back, I've saved lots of money. And the question is, and we haven't really seen a lot of this, is if I send them to an assisted living community where they're going to do a great job and send them back, all of a sudden assisted living becomes a huge win. So as it traditionally is looked, when hospitals looked out on the world of post-acute care, they saw skilled nursing, home health, assisted living, and they'd all sort of looked the same. And it was a necessary evil, it was part of the system, and it was almost, you sort of dumped your patients off into one of those things, and you didn't have to worry about them anymore. Those patients became someone else's problem. And so even today, and even with the new healthcare paradigm, I think what we're going to see happening is that the world is going to continue to look like that, except that as the hospital looks out there, they're going to see a few skilled nursing communities, they're going to see a few assisted living communities where they have discovered that they can trust them, they can send their patients there in a post-acute setting, and they know that to the extent possible, they will be able to keep them from being readmitted. And this ultimately, you know, even though the dollars are driving a lot of this, this ultimately means that the residents are better off, because we know that moving residents, seniors in particular, is really hard on both their physical health and their mental health. And so the goal really is for an assisted living community is to be one of those few that's really a privilege for the hospitals to look at them and say, man, those are guys who will make a difference for me. They will save me money. They're doing a great job. They're doing a great job for the patients. They're going to make us look better in the community. So I don't know the specific rules in Colorado, but what I see in probably 75 or 80% of the states is that with waivers, most states can do about 80 to 90% of what a skilled nursing community can do. One of the big benefits that you have as an assisted living community is that you can actually, for the same dollars, provide more direct resident care than a skilled nursing community can, because you don't have the same regulatory and documentation requirements. And so I've seen some studies with some communities that are already doing this, and I'm seeing numbers like an hour to an hour and a half more direct care for the same dollar amounts, because just the way the system works. In addition to that, you've got better food, better rooms, better beds, really better everything. And the big takeaway is that as you look at doing this, you need to be able to say, I can keep them from going back into the hospital some percentage of the time. And part of this process is being able to keep some statistics to demonstrate what you can and can't do. So what do you need to do to be able to put yourself in the position to provide these kinds of services? First thing is you need licensed nurses. In the bigger buildings, I see RNs 8 hours a day, either 5 or 7 days a week, LPNs around the clock. Smaller buildings, you can't always do that, but you're probably going to need to be able to have nurses in the building at least 8 hours a day, 5 days a week. You need to be able to have rehabilitation services. Those are typically contracted out services. You might find a situation where your agreement with a healthcare provider on Medicare Advantage would be that you would actually be responsible for payment. In other cases, they would get billed separately. Rehabilitation services actually becomes potentially a revenue source for you if you've got dedicated space that you can rent to them. And so it creates some opportunities. You obviously need a lab, x-ray, pharmacy, hospice. One of the other things that I'm seeing that's really fascinating to me is that more and more communities are making arrangements with physician groups where the physicians will actually come to the community to see residents. Now, it does mean, of course, that you've got to create real strong incentives for your residents to use your chosen physicians. But if you're in a situation where you can have physicians or physician assistants in your building every day, 5 days a week, it will be a huge win for your residents. It'll save you on transportation costs, and more importantly, it's better for the residents, and it will create a better story for you to tell the acute hospitals and the healthcare maintenance groups. And so as you're looking at this, I think that sort of what I see in both skilled nursing and assisted is that we all tend to feel pretty beholden to the physicians. But the truth of the matter is we're bringing patients, we're bringing revenue to those healthcare providers, and it needs to be at least a partnership, and perhaps you even need to be looking at it in terms of presenting an opportunity for them to help them build their practice. And so one of the things I like about this changing environment is it does become more of a partnership where the bottom line is that ultimately the costs go down and residents get better, more comprehensive managed care. So you need to be, the next thing is you need to be able to tell your story, and record keeping is the key to that. Traditionally what's happened in both the skilled and assisted is that the state sets a standard for record keeping, and so everybody says, okay, I'm going to meet those standards because that's what I've got to do to stay out of trouble with the state. Also, take a look at record keeping might be a little bit enhanced above that because what I want to do is I make sure I don't get sued. And that's it. Payer sources may have additional requirements. That would probably be more true for skilled nursing. But the thing that is really important to you as a provider to residents is to be able to keep statistical data that will demonstrate that you provide a higher level of care than your competition. You need to be able to demonstrate where your residents came from, what kinds of conditions they had when they came in, what their length of stay. You need to particularly keep track of hospital admission and readmission data, and so that you've got some real documentation that you can go in and tell your story effectively. So you need to create care systems that are designed to provide excellent care. The systems need to reduce hospital readmissions. There's a group called Interact out of Florida that has done some pilot studies and created some programs that were primarily done for the skilled nursing environment, where in their early pilots they were seeing a reduction in hospital readmits in the first 30 days of as much as 50%. What they're seeing now that the programs are being rolled out and implemented in the field is anywhere from about 17 to 25%. The web address is here, and Peter, I guess, I'm not sure how we can do this, but we can certainly make some of this stuff available to people if they want to access it after the session. The good news is all that stuff, all the tools that they have are all free. So I would really, and they've got some assisted living communities that are using these tools very effectively, and so it's just a great way to begin to sort of take your care level to the next level. The couple other things I just want to add is there's always a danger of working so hard at preventing readmits that you actually put your resident in danger, and so I just need to add that you need to never, ever, ever, ever put your resident in danger. You need to be educating your staff. You need to be educating your physicians. Emeritus has this chant. My wife works for a company that does software for skilled nursing, and she does a lot of work with them, and so she gave me this. We were talking about this last evening. She says that the Emeritus has got this chant that goes, the best thing for the resident every time, all the time. And I think that that's a really great sort of approach to taking care of residents. So what do you do with all this once you've got there? Tell your story to everybody. Meet with hospital administration. Go above discharge planning. I don't know what it's like there in Colorado, but I know that in most marketplaces here in California, discharge planners will hardly talk to or meet with marketing people or administrators of assisted living, in particular to a lesser degree skilled nursing, because what they prefer to do is to point families to a place for mom or one of the other placement agencies and offload that burden on the placement agencies. And so and as you're telling your story that you can make a difference in this readmit, you'll find that what ends up happening is that that's not what the discharge planners only care about, getting people out of the hospital on time. That's sort of not where their emphasis is. You need to be talking to the people who are watching the bottom line, and so it's going to take persistence. Not easy to get in front of hospital administration, but it can be done. You need to find Medicare Advantage plan contracting officers and care managers to tell them, to let them know that they ought to be looking at you as an alternative to skilled nursing, that you're going to be able to provide comprehensive care for fewer dollars per day, that because you're providing a better environment, a more home-like environment, better food, better sleep, better care, better nursing, you are you're going to make them look good and you're going to save them money. So how do you do that? I think probably the best way is to start by talking to some skilled nursing facilities that have contracts already. It's not an easy thing to do. It's a long, drawn-out process. I've got a friend in Southern California who is a care manager for one of the big senior health insurance providers down there, and we were having a conversation a few months ago about assisted living, and it's not really, it hasn't been, it's not on her radar. And we started talking about how often she's got people where she's got them. What happens for these healthcare plans is hospital says this person's ready to be discharged. That nurse case manager needs to make the decision. Do they go home with home health? Do they go to skilled nursing? Do they go someplace else? A lot of times people fall in between. They fall in between. They're almost always going to go to skilled nursing. And assisted living becomes a perfect opportunity for them. And honestly, I bet probably 20 to 30%, based on my conversations with her, of the residents there that she is currently placing in skilled nursing could just as easily go into an assisted living environment. And so you've got to find these people and start telling the story. The other thing you need to be doing is getting newspapers out to talk about what you're doing, about how you're amping up your services, talk to home health, talk to hospice. The more people you tell the story to, the more threads you'll find that you can pull on, and they'll start opening doors. Again, don't be afraid to ask these people as you talk to them to make introductions for you to other people, introductions to hospital administrators, those kinds of things. And I guess that's sort of really it. I think that what you really have is an opportunity to go out and tell your story to sort of change the mindset, to keep your residents longer because you've got better medical interventions. And I think that one of the things that I didn't really talk a lot about, but there are some programs like PACE, which are primarily geared to serve the needs of dual eligibles, meaning they're both Medicare and Medicaid. So you might look at that, and if you're primarily private pay, say, nah, I don't know if that's really worthwhile. But some of those people will likely turn into long-term stays, and even short-term kinds of things can fill beds that you wouldn't otherwise fill. And as you do that and you provide care, word of mouth is a very, very valuable thing. And so with that, open it up to questions.
All right. If you guys have questions, you can ask in the chat box, or if you click the raise your hand, you want to ask Steve a question, just raise your hand and I can unmute your microphone. One question I had right off the bat, Steve, on the nursing side of it, we have a lot of smaller communities that are owned by nurses. So the nurse, she's in and out of facilities constantly. Do they need to be at every location 8 hours a day, do you think, for this? Or if they're pretty much available, throughout their locations? Or what's your opinion on that?
So it's a really good question, and in California, so Medicare has a program called a Medicare waiver program, and I don't know whether you guys have that in Colorado. Peter, do you know offhand, or does anybody know if you've got a waiver program for assisted living in Colorado?
I'm not sure on the Medicare side if we do. Any of you guys know?
So yes. So let me just, this is sort of a long way of answering the question. So
Sure.
We have a pilot for we have a pilot program in California that just covers 7 counties, and basically what it does is that it allows, actually allows Medicaid dollars to go to assisted living for people who would be sort of roughly analogous to needing intermediate nursing care, or so it's not continuous 24-hour nursing care. And I've got a good friend of mine who has a community, an assisted living community that operates under this program, and so he gets anywhere from an additional $1,000 to $1,500 a month that comes through the Medicaid dollars. Because it's less expensive than paying a full boat Medicaid, in California's case,
Right.
Medi-Cal, to the skilled nursing building. And they do not have a full-time nurse. They have a contract nurse that comes in
Okay.
A few hours a day.
Okay.
So
I
think that works fine. I know that's sort of
Gotcha.
a long way of answering the question, but
Yeah, no, I think that, a lot of them, and even some of the smaller communities that maybe have 5, 6, 7 locations, kind of have a nurse that kind of roams around to different locations.
Yep.
We do have, we've got some good companies on the rehab side that will come and do rehab. We have companies in Colorado that we have some doctors who are very good about making house calls. We've actually got a mobile X-ray and diagnostic company now in Colorado that comes in and that can do that stuff. So there's a lot of services that are available, where like you said, you don't have to do it yourself. You basically just partner with them.
Yeah.
So.
Well, I mean, most of the, I don't know of any assisted living communities, even very large ones, that would have that they will typically have on staff the nursing. Although with smaller buildings, you might if you have somebody who's a nurse who's an owner, then that's terrific.
Right.
But you can also contract out for those services.
Yeah.
But things like the ancillary stuff, lab, X-ray, pharmacy, those kinds of things. Even the very, very large buildings, that's always a contracted out service, and there are lots of good reasons for that. One is, as I talked earlier, you have the potential of creating additional revenue if it's a larger building where you've got space that you can lease out to them.
Right.
But they also have the ability then to bill directly to Medicare or to other financial resources so that it's not coming out of your pocket, and you don't even have to deal with the billing. You just take advantage of the services to do a better job of taking care of your residents.
And Jeff, I see your hand there. I'll get to you here in just a second. I want to kind of address one question that came in talking about reimbursement rates expected to change under Obamacare for Medicaid for assisted living facilities. So I think there's two avenues of that. I know on the state side, in terms of Colorado, Colorado does not have a very progressive Medicaid program for assisted living. We did, I'm not sure if I talked to you about this, Steve, but we introduced a bill, Colorado Assisted Living Association introduced a bill this year to create a pilot program that would increase the Medicaid reimbursement, and with the idea of being able to make more Medicaid beds available in assisted living. Because right now the reimbursement's only around $2,000 a month. And our proposal in the pilot program is $3,000 a month. So the bill passed. We got the bill through. The hard part now that we're working on is the regulatory side, is how do they actually implement that program. But so from that aspect, I know that we're trying. So Medicaid in general, I'm assuming it's more of a state decision than it is a Obamacare decision for assisted living.
Well, I think that I think that it still remains to be seen. If I were just to guess, I'm assuming that over time we will actually see more Medicaid dollars available to assisted living, and so what you're actually describing is it's obviously a very different type of waiver program, but it sounds like it's a version of the waiver program that allows you guys to get Medicaid dollars, and it's actually more generous than California, because I think the maximum we can get in California is about $1,500. Plus, there's a supplemental Social Security, so I don't know whether that number you're talking about includes the SSI as well.
No, that's just Medicaid.
And so how much, just asking you a question, how much nursing has to be done? I assume that you only get that money if there's some nursing intervention taking place?
Nope, not for Colorado. Nope.
Okay, interesting.
Let's see. All right, so let me unmute Jeff there. Jeff, are you there?
I'm here.
All right, go ahead.
I'm calling from Cliffview, which is a 24-unit facility out in rural Colorado. Question I would have, if I'm hearing this correctly, we're amping up our services and our level of care would increase as well. What would we have to do with the state as far as the regulations go to meet the, because the guidelines would have to be expanded a little bit, wouldn't they?
So Peter might be able to better answer that question than I can. I know that in California, and I'd say probably 40 of the 50 states, there are huge amounts of nursing intervention that can be done under a waiver program. I've actually, talking and sort of wearing my nurse call system hat, talking to some people who are doing assisted living, and it sounds like, again, as Peter said, you guys are pretty progressive, and it sounds like the state's pretty aggressive about allowing waivers. I know in the state of California where I live that there are all the sort of really strong limits to what can and can't be done, but again, if it can be done safely, there's a waiver program. So Peter, you probably can actually answer that better than me.
Yeah. So in terms of what you're proposing, and honestly, it's not a concept I think we've really have thought much about. In terms of, here's the level of care that I'm providing that's beyond assisted living. There's a lot of assisted living in Colorado that don't have nursing staff. They have contracted services that come out, from time to time, but in general, a lot of them don't. And that's state regulations for assisted living. So, what you're talking about is actually going to these different agencies and saying, here's the level of care that I'm going to provide that's above what the state is telling me to provide so that I can provide this level of service. So I don't know that for Colorado, honestly, we have a regulatory requirement that you're having to meet. And, I think it's more of this is what I'm doing as a community to provide for seniors. So I'm going above what the state requires for assisted living, but I'm still not a skilled nursing facility.
Yeah, I mean, there are going to be probably some things you can't do. You're probably not going to be. You wouldn't be able to do things like central lines, and probably wouldn't do feeding tubes. So maybe you could. I don't know if you had somebody who was stable. So I think that it's going to be there probably need to be some give and take with your licensing people to really just have a frank talk about what you want to do and what you can and can't do and what you need waivers for and that kind of thing.
Yeah, I mean, I think, definitely. I think it's going to be, here's what I'm going to do, and you're going to have to go to the state and go, if I do this, this, and this, and I have this staff in place, can I do this? And it's probably going to be a case-by-case basis.
Silverado, which is probably the largest straight memory care provider in the country. They're based out of Southern California. They're just finishing up a building in Colorado. And now that particular building actually has both skilled and assisted, but they're typical even in their assisted living model is a pretty medical model. And so they have nurses doing nursing kinds of interventions. And one of the challenges and reason why the physician relationships become so important is that traditionally what's happened is you have a resident, and this would be true whether it's assisted living or skilled, who has a change of condition, and as a result of the change of condition, they need some physician intervention. A lot of times the nurse will even know what needs to be done, but they can't make that decision without a physician's order.
Right.
Physicians, real easy for the physician to say, send them to the emergency room.
Right.
And they can deal with it because I don't want to come out on Sunday night. And so creating a system where you can avoid those kinds of things makes a big difference.
Yep. Does that help, Jeff?
Yes, it does. Thanks.
Okay. All right. Other questions, folks? Well, in general, Steve, I mean, great information. I think that opens some possibilities for those that want to, kind of delve into that area. But I mean, it totally makes sense. I mean, there's a lot that assisted living can do, with just a little bit of increase in care, to be able to, meet the needs of a little bit different audience, maybe than what they've been trying to do, and it's like you said, these discharge planners and that kind of stuff, they're just trying to move somebody out, and you might as well get them in your assisted living facility, even if it's for a short time, because them and their families are now introduced to a different model that maybe they hadn't seen before. And so
Exactly.
maybe they go back and they live with their family, or they go home, but at some point they're going, you know what, that assisted living was pretty cool. You know,
Yep.
and maybe we need,
No question about that. And so and again, the more people you can tell your story to,
right.
The better off you always are. And so I guess that's sort of, for me, the bottom line is that the most difficult part, and really there are two parts, really, is being able to tell your story to lots of different people, and the other half of that is being able to tell a story that's more compelling than
Correct.
the story that somebody else is telling.
Well, and you mentioned it early on. You're dead right. Everybody looks the same. So it comes down to what's the closest one to my house or the closest one to my family's house, and that's where I'm going to put them. That's one of the biggest factors. So how do you then go to the next step and make yourself really different, and in order to actually someone look at you and go, oh, well, they're not the same as them. They do more. And so being different is a critical, in any kind of marketing or anything I do, is how do we make you different than anybody else? And that's
Exactly
a key
right.
factor. So anyway.
Yeah.
All right, very good. That's awesome. I appreciate it, Steve. Thank you so much. Great information. I'm going to definitely get this out to our membership. I think it's really key information that everybody needs to be aware of and know what's going on. So thank you all for joining us. Yes, they're asking for a copy of the PowerPoint. So, Steve, I'm sure you can send me the PowerPoint. We'll
Yep,
make that
I can do
available
that.
to everybody, and so that everybody can have a copy of that. And thank you once again for joining the Colorado Assisted Living Association. Again, it's Peter Brissett here, and we've had Steve Moran with us from Vigil. Sorry about that, Steve.
Not a problem. Not a
Vigil Call Systems and SeniorHousingForum.net. So go read his blog, and great information. We'll make sure we're sharing that with our membership as well. So thank you all, and have a great day.
Thank you very much.
Thanks, Steve.